Northern Education Research Day 2025. We expect that this room will slowly fill out as we have the conversation based on our registration. So just kind of make space for people as they come in. It's a full and jam-packed day that we're really excited to deliver to you, highlighting and showcasing all of the education scholarship that happens in the Faculty of Health Sciences here at McMaster University. My name's Lawrence Merson. I'm the Assistant Dean for the Health Sciences Education Graduate Program. This is a professional degree granting program that invites and welcomes an interdisciplinary group of learners who are clinical educators largely, who are looking to build mastery in teaching and learning and building education structures and assessment and simulation and all of these things that we do in our health professional training space. It's a large group, and if I could get a show of hands, how many HSED folks do we have in the room right now? Past, future, present? Yeah, so you'll see that we're everywhere out there. And it's been my pleasure in this role to slowly work to build up the Education Research Day. The first one that we did just next to Williams in the hospital. It was a small room, and it was just a few presentations of thesis students giving their final dissertations. We had some pizza, but we've been moving along this path of developing it with our partner program. It was called PERD at the time, and it was led by Dr. Jeff Norman, who we now name the day after. The Norman Education Research Day is in honor of all the great work and scholarship and support and mentorship that Jeff has shown to our health professionals education community over time. I've asked Jeff not to speak right now because we have to get going and we've got to fit it all in. So, but he wants to talk to you throughout the day. So he's looking forward to you stepping up and working with him. But we've been working with PERD and at the beginning and eventually over time we were grateful to welcome Dr. Jonathan Sherman as the Assistant Dean of PERD at the time when he started, and he brought his undeniable razzle-dazzle to our group, and we switched from PERD to merit, and you start to see this day, really embed itself into the faculty's annual calendar, get on people's radar, and we went from a few people in a small room to this large event here, which is a real hallmark and capstone. So Jonathan's also hoping that you're going to walk up to him and talk to him today, and he's got lots to say too. So that's also why we save him for the end when everybody's ready to get going, because otherwise we don't get to any of the talks that we get these guys speak. And now I'm starting to do it. So, I'm gonna put a pin in it. Before we get going, though, it's important that we take a moment and acknowledge the lands that we're on and the traditional lands and the people who are the traditional inhabitants of the lands that we are on. We do a land acknowledgement to help us reflect on our time and the way we interact and share the resources and the space and the communities that we live in. McMaster is located on the traditional territories of the Haudenosaunee and Anishinaabe peoples, and is covered by the Dish with One Spoon Wampum Agreement, which is an agreement that was formed between the Iroquois Confederacy and the Ojibwe and the Allied Nations. I'm not going to stop there, though, with the acknowledgement. I've noticed as we're doing these reflections at the beginning of meetings, that slowly we've stopped to talk about the treaties that are typically named within these acknowledgement moments. And it's important that we bring that back into this moment. And it's something that we'll talk about with the HSED students throughout the week and throughout your time in the program, is this idea of structural competency and becoming aware and knowledgeable of the systems and the structures and the policies and all of these things that we build out around our relationships that offer governance and regulations to the way we work. And so we're supposed to talk about the treaties when we do an acknowledgement, or that there isn't a treaty, that the land is in some cases unceded, and the sharing that we're talking about is actually experienced as occupation by some folks. But to highlight that we have this policy set that governs the relationship, it's supposed to govern the relationship, and often we're living in violation of it. So here, these lands and the ones adjacent are governed by the Upper Canada Treaties and the Haldeman Treaty. And so, as I'm sort of giving this reflection here, I'm hopeful that as you move through the sessions today, and you're hearing talks about education, that you're able to think beyond this beautiful dialogue, this beautiful exchange that happens between teacher and learner as the core aspect of education, and to also pay attention to the structure, systems, and policies that govern our education space, that have the power and the potential to make it an impressive environment, one that perpetuates inequities, but also gives us the potential and power to be transformative in our practice and the way we create equitable and inclusive spaces. So that's my request to you as we go through the day. I'm going to move right into introducing our keynote speaker and getting started on this. We have an interesting arrangement for today. We're going to have a keynote speaker who's going to come and talk to us about epistemic community in the context of interprofessional education and interprofessional practice. It's an important time for this conversation here in Ontario, certainly, as we're thinking about greater investment in primary care teams to meet the needs of the population and to improve access to care for all. After we have this talk from Aliki, who I'll say some things about you before I get down here, we're going to move on to a distinguished panel of guests and experts who bring unique views on this idea of epistemic community and interprofessional practice in the context of building healthcare teams for primary care. We have Dr. Cathy Risdon from the Department of Family Medicine, Ruth Hannon, who brings a nurse practitioner perspective to our conversation, and Dr. Karim, Vellani, who's with Shoppers Drug Mart, who's going to talk to us about corporate pharmacy and the role it plays in this space as well. And they'll each going to take a moment and give themselves a little bit more introduction so you hear less of me when we're doing the talk. But before we go, I'm really grateful to be able to welcome my friend and colleague, Dr. Aliki Thomas, who's a PhD and a clinical occupational therapist, and is an internationally recognized researcher whose work bridges education, practice, and policy to advance evidence-informed rehabilitation science. She leads the K.E.E.P Lab at McGill University, where she develops person-centered strategies to close the gap between research and clinical practice. She has 1 million publications, over 145. She's delivered 1 million presentations, over 225. I don't know why I put these numbers, it should be 1 million. And has secured over $1 million, actually over $12 million in research funding. She's an associate professor at the School of Physical and Occupational Therapy at McGill University and Canada Research Chair in Education, Practice, and Policy for Evidence-Based Healthcare. So without any further ado, enough from me. Aliki, please come take the stage. Round of applause.
My microphone is working. Oh, thank you so much. No, heaven forbid 1 million. No way. Thank you so much for that lovely introduction, Lawrence, and thank you for having me. MAC holds a very special place in my heart. I won't share all of the stories for why it has a special place in my heart, but suffice it to say, I did my postdoctoral fellowship here with the Camchild Center for Child with Disability, working with Dr. Mary Law, who's now retired. But lots of my OT peeps, like my besties, are in this school, in this program, one of whom is sitting right here. But I also have really wonderful collaborations and friends at Merit. And I'm so excited to be back. So thank you for having me. So I'll just give you, I know that folks always want to know how long is she going to talk. I literally have 35 slides and about 30 minutes, so that's about to give you a ballpark. So I'm going to zoom through things because I really have some, I hope, some good questions that we can all discuss with our panel. So why did I choose the title Storm, Silos, and Synergy? Because I think it captures the emotional and the structural landscape of interprofessional work in health education and practice. The storms, I think, represent the tensions, the competing priorities, the institutional constraints, and the cultural clashes that we navigate daily. The silos, I think, speak to the persistent structural and epistemic divisions, and I'll talk a little bit more about epistemic communities and epistemic identity in a couple of minutes, that keep us sometimes, much to our chagrin, the professions apart, even when we're ostensibly working together, should be working together. But I'm not really here to sort of dwell only on the storm or stay stuck in the silo. Really what I want to talk to you about today is synergy, and not as a buzzword, but as a serious proposition or a provocation for reimagining how we could collaborate. And so I'm going to be exploring throughout the talk the notion of epistemic communities, and then sort of call on you on the panel to see how, to what degree that concept resonates. And can we apply the concept of an epistemic community towards interprofessional teams that are working to address serious issues related to access to care and primary care? So, so I think that, well, let's see what you think. As healthcare professional, our aim is to provide person-centered, evidence-informed, equity-driven care. So, how many of you agree? John, do you agree? How many of you think I've fallen and hit my head, my marbles? Okay, so this is really what we're here at, right? It's a bit of the obvious, I think, objective for everybody in this room and for those of us in health professions, education, but also practice. And these core principles are often used to describe patient-centered care, right? And I don't need to go through them. They're written. There are many authors that have written about what is really patient-centered care. They're not going to be new to anybody in this room, but I think it's worth pausing to consider how they continue to guide and sometimes even challenge our everyday practices. So we're expected to deliver patient-centered care, right? And we're expected to uphold the principles of person-centered care, which often can feel like we're trying to do this in the middle of a storm, right? Navigate overwhelming complexity, moral distress sometimes in healthcare professionals, and last but not least, systemic strain. And I really, there's not enough room in my slides to really show you or take all the screenshots that have gone through the last few years in the media about the degree, the disheartening deadlines about the degree to which it's become increasingly difficult to work in the healthcare system, but there are also very, very difficult, urgent and complex challenges. And these are some of them, right? There's bodies of work on every single one of these, and I don't, that my point today is not really to go through all of these, but when you talk about staff shortage, we know that, right? And funding and constraints in terms of resources, and AI, the rise of AI and what that means for us, and for all the healthcare professionals, our populations are aging, and our training and education, I think that Lawrence alluded to a little bit at the beginning, is that we also need to train and educate and prepare practitioners to face some of these challenges. And my challenge, I think, to all of us is how do we remain nimble across these different challenges. And all of this is happening in a world that desperately needs empathy and humanity. And these forces in the previous challenges, they're reshaping our professions, right? They're challenging us to rethink or reimagine how we learn, how we adapt, how do we acquire new knowledge, how do we grow in our systems. So when the storm hits, whether that's in the form of a policy shift or a resource scarcity or upheaval in organizations, I know they're happening in many provinces, they're certainly happening in Quebec right now, we often retreat to what we know, right? We retreat to our disciplines, to our departments, to our professional cultures. But in healthcare, that kind of instinct to sort of bunker down fragments teams. So we double down on our scopes and we defend our territory and we lose the opportunity to respond to the complexity together. And so silos might at times feel like they protect us, but they also isolate. And they limit our capacity for meaningful collaboration when we need it most, but when our end users, our patients, our communities need it the most. So as we're witnessing a healthcare system in urgent need of healing, and as people across our communities are increasingly struggling to access the care that they need, interprofessional practice, patient-centered, coordinated care, community-anchored care, they're not luxuries, right? It's not a luxury to think that we need to really come together and provide this kind of care. It is more than ever a necessity. And here's the quiet truth, right? 3 little secrets that I think you might share. There's never been, at least in my life, in my lifetime, I don't know what Jeff thinks about this, but where we have worked alone in isolation or are going to, have been expected to not work together, right? So there's lots of evidence. We know there's a lot of research on interprofessional practice, policy accreditation bodies across countries, including our own, and of course embedding ideas of interprofessional practice. The health systems, the aging populations, the complex comorbidities, and our educational institutions that are really, really now more than ever scrutinizing what it means to prepare graduates for interprofessional practice and restructuring curricula. Yes, we've been restructuring curricula for at least 20 years, if not more, but I think now there's an accountability and there's a system in place to say, are we doing this and are we doing it authentically to really meet some of the challenges that I mentioned earlier. And across Canada and globally, we know this, there's streamlining operations through digitalization and centralized referral systems and integrated care models. There's cuts, huge cutting costs by prioritizing cost effectiveness, shifting care from hospitals to more community, as you know, replacing outdated systems by AI-enabled tools and electronic health records and others, and reducing waste. We hear that a lot about targeting inefficiencies, overusing certain diagnostics or health and hospital systems, so hospital administrative procedures. But so while these efforts are really necessary, the risk is that cost-cutting or system overhauls without equity and clinical insight can compromise the care quality or the access to care for vulnerable populations, right? I showed you a few examples. So, this trend is real, but how it unfolds is going to depend on leadership, on governments, and on a lot of different interested parties. And sort of the last, little secret is, and I know you know this, so it's not really a secret, is that as we make progress in certain areas, other challenges are going to arise, right? We've made strides in polio and HIV survival and COVID-19 vaccines, but now we have other issues that are cropping up, right? So antimicrobial resistance, climate change, aging populations, and many others. So it's not going to stop. We're going to be solving some problems, and other problems will be emerging. But staying in our silos makes it almost impossible to harness the very thing that we need most in a storm, right? And that's shared insight, coordinated action, and an acknowledgement that we all have different epistemic identities, right? The way that we view knowledge, and I'll define it in a second, right? And the humility to admit that the knowledge that we all have and the knowledge that we share, it doesn't sit neatly in silos, right? It emerges between people. It's collective, it's contested, it's alive, right? We get to work with that knowledge. And so that's where synergy becomes not just ideal, but essential. So what is this epistemic identity that I spoke to you about before? It's really about how we develop, acquire, validate, and apply knowledge, what we all deem to be credible and reliable, and how we engage and integrate various forms of knowledge both within our own professions, but beyond, as we try to support our patients and our communities. And your epistemic identity, everybody's epistemic identity in this room, is shaped by several things. It's shaped by your disciplinary training, right? Where you come from, the programs that you've been deeply steeped in, culture, personal experience, and even institutional norms, right? All those things influence, for example, how clinicians understand and apply knowledge. Right, an example that I like to use is someone who's deeply rooted in evidence-based practice, like in the home, may prioritize, for example, in some cases, randomized clinical trials. When someone has a more pragmatic or humanistic lens, they might integrate patient narratives and experiential knowledge in addition to results from trials and other sorts of research designs of that nature. So now, we are in the home of evidence-based medicine. I really recognize that. Evidence-based practice was the topic of my PhD work. It's been in the heart and soul of my work in the last 15 years. And like I said earlier, I trained in this very faculty for my postdoctoral fellowship. And with having said all that, I am a proponent of the very important factor that scientific evidence isn't the only form of knowledge that is required within increasingly complex patient populations, nor is it enough for many of the global challenges we face today, including some that I showed you earlier. So complex problems, yes, we need to tackle them with empirical scientific evidence, but it's also going to require other forms of knowledge, right? The practice-based knowledge and the intuitions clinicians bring in, the patient knowledge, the aesthetic knowledge that when we talk about aesthetic knowledge, we talk about the beauty in the relationships. We talk about that deep embodied understanding of a lived experience. And we're also bringing in indigenous ways of knowing it, and there are others. Understanding that all of that isn't context independent, that context plays a crucial role in how we acquire that knowledge and how we mobilize or how we apply that knowledge. So this means that as we're thinking about collaboration in complex care, we need to embrace epistemic plurality, right? So we need to reimagine how we work together. We need to value the collective wisdom that comes across different disciplines, integrating the different voices that have often been silenced. We need to consider that we need to work with public health and urban planning and economics and engineering and sociology and epidemiology, and the panel might have some thoughts about this. And integrating, again, most importantly, traditionally excluded voices from planning and care. And I really want to emphasize that. I think Lawrence alluded to that a little bit at the beginning, but I am a huge proponent of where are the voices of the individuals for which this knowledge matters most or more than necessarily those like myself that are on, the proverbial ivory tower. And we also have to be able to challenge assumptions about what constitutes knowledge and what is evidence, and to broaden our understanding of all of that with respect and humility. So how do we do that? How do we ensure this more pluralistic yet rigorous approach is not just acknowledged but upheld? And this is where I propose to you that epistemic communities become critical. So what I want to talk to you about for the next 5-10 minutes is epistemic communities. What are they? Who belongs to them? And how can we use or rely on that lens as we move forward with the vision and mission of integrating, improving access to care and working in teams in primary care? So epistemic communities are more than mere knowledge-sharing networks. They define what constitutes legitimate knowledge. They validate, mobilize, integrate different ways of knowing into systems that have the potential to influence care and policy. And epistemic communities advocate for incorporating into health systems the knowledge, the multiple ways of knowing, in ways that are both rigorous and acknowledged. And this happens by guaranteeing that that knowledge remains responsive to social and policy context. And it's more about the social, the policy, and the global context that I think is really interesting when we talk about epistemic communities. They've long been instrumental in tackling complex global challenges. They didn't come out of healthcare, right? There's been a body of work in about 30 years or so from sociologists and political scientists that have talked about epistemic communities. Let me give you a couple of examples. Collaborations amongst biologists, environmental economists, policy experts in climate science have really shaped significant international policies like the Kyoto Protocol and the Paris Agreement. And we've seen this also with the WHO's reliance on networks of epidemiologists and public health experts and lots of different medical professionals. And those sorts of collaborations and initiatives have been instrumental in coordinating responses to crises such as HIV/AIDS, SARS, and we recently saw it with the COVID-19 pandemic. So what these communities do is that they adeptly incorporate viewpoints from these different experts from various fields to create a more nuanced set of strategies to diminish inequalities, promote more inclusive policies, and drive systemic change. So Peter Haas was a sociologist who coined the term epistemic community in the early 90s. He introduced the concept as networks of professionals with recognized expertise in a specific domain and an authoritative claim to policy-relevant knowledge. Now you might be asking, who belongs to this? Am I a member of an epistemic community? Who gets to be part of this fancy group? Well, membership in an epistemic community, is it a matter of expertise, recognition, or power? So Maya Cross is someone that's worked very much in this area as well, and she argues that they're not simply the entirety of a profession, right? So it's not just necessarily a group of OTs or a group of physicians, nor are they limited to members of that profession. So while these communities are often linked with scientists, they often notably include non-scientific experts. So you get lots of different professionals, but you can have policy analysts and advocates and patient groups and community organizations and NGOs and any other knowledge holder, not just scientific or technical fields. But what's really important about epistemic communities is that they're legitimate because their members are regarded as credible in a particular area and can achieve consensus on essential issues that are ailing our world, and in our case, our healthcare system. But their influence, what's important here is that their influence isn't inherent. It's shaped by evolving power dynamics and political factors that determine how the contribution of each member is recognized and then implemented in policy making and decision making at more global levels. And just to bring it a little bit more home for you, I want to share a glimpse or an example of an epistemic community that I am part of. So I've been working at trying to really bridge education, practice, and policy for a very long time. And literally about 5 years ago, I was just pacing in my living room and I said, this is not enough, so we have to do something different. So I realized that much more was needed than what I was able to do just with my very close collaborators. So we built a broader, more connected network that spans lots of different disciplines, which you can see on the left. But we also brought in sectors, industry, and academic institutions, and hospitals, and community organizations. And at its core, vital, it's that our epistemic community is anchored by frontline professionals, OTs, physios, physicians, chiropractors, nurses, etc., working across primary care, rehab, and community settings. And our epistemic community brings these diverse actors together to co-design, disseminate, and implement rehab-informed care models that are going to be accessible, sustainable, and embedded in everyday healthcare. It hasn't been easy. We've had to align a lot of different things. And here are the 4 major components of what makes a group an epistemic community. The first one is shared values. So I'm going to describe briefly each one, and then I'll tie it into the epistemic community example that I just gave you for each one. The first one is shared values, right? This is a commitment to sharing values which unite the different members around common goals and ethical principles. So the community is grounded in a shared commitment to truth, acknowledging that truth might be different for different individuals, and prioritizing credible scientific knowledge over personal or political interests. In our case, our values, what's held us together is that we believe that access to timely, person-centered, evidence-based rehabilitation services are a right, not a privilege, and that this is only possible via interdisciplinary collaboration. The second one is a shared understanding of the root causes. This is really, really important. This is about everyone in that group saying, okay, we believe that it's not because of one reason that there's limited access to rehabilitation, for example, that the causes are not just clinical, they're political, they're systemic, they're organizational, they're financial. There are a lot of different reasons for why that is the case, and that's how we've been brought together in terms of our shared causal beliefs. The third is a shared understanding of what constitutes valid and reliable knowledge, and that's going to be part of our discussion with the panel. And it's about common standards that guide how different members evaluate the evidence, solve the problems and make policy recommendations. And this is very much about personal responsibility, where each member contributes the knowledge that they're coming with within a respectful environment, and they share the standards of evidence. In our case, it's evidence, lived experience, contextual nuances, and we measure success not just through results of randomized clinical trials, but through real-world impact and cultural responsiveness. The third one is sorry, I said this one. And the last one is the commitment to action. And the commitment to action is really what galvanizes an epistemic community, is that we're going to move forward and we are going to try to move the needle on policy. We are going to commit to action together. And that's what we've been doing with our epistemic community, is that we are moving towards sustainable, equitable rehab models. So for you, in terms of epistemic communities, and for today, for this talk, in terms of interprofessional practice and primary care, what can I offer? What are some of the things that I want us to think about? So the potential of epistemic communities to advance the agenda and the mission of primary care is significant, at least I think it is. Especially as our health systems, as I said earlier, grapple with such complexity, equity, and in the integration of diverse knowledge systems. So how can we do this? How can an epistemic community make a powerful impact? So I'm going to propose that this is possible through 4 different mechanisms. The first one is really about broadening our knowledge base for primary care. And again, I will discuss this with our panel, right? And it is more, it's beyond biomedicine, integrating knowledge from public health and social sciences and indigenous knowledge and lived experience and all of the social determinants of health. It can help primary care address the social determinants of health, but in a more equity-driven manner. And the second one is more about the practice-based evidence. So I don't want us to cringe or have like an allergic reaction, but practice-based evidence, the sort of thing that comes from intuition and practice, is vital. You know, we need to legitimize forms of knowledge other than what, often, and those are often excluded from policy making. And we need to push for models of care that are more context sensitive and locally grounded. The second one is about that cross-sectoral dialogue. And I know that every time somebody stands in front of me and talks about we should speak to each other, we should collaborate, we should sit around a table, hold hands, sing songs, it's not about that. And I'm very cognizant that that doesn't always work. And this is why I'm bringing up this notion of epistemic communities today. I'm very well aware of how challenging it is to collaborate. And I think there's been a disservice done in health professions education programs by believing to some degree that if we get people around the table in a classroom to really talk about the challenges, it's all going to do well and it's all going to lead to these wonderful teams who can work together. I've sat in those environments and more than one person has fallen asleep. And it's not just a fatigue, right? It's really a matter that to what degree are we able to collectively bring our voices together. So we need to facilitate dialogue amongst clinicians and policymakers and educators and patients, and we need to try to almost force those kinds of discussions, and they need to be done based on some of the best practices, right? Recognizing that we have different missions, different visions, different currencies, and so whoever is at that table moderating those discussions needs to really be cognizant of that. Bridging professions, I know we can talk days about how do we bridge professions, right? But if we have a little bit more epistemic humility, that humility to understand that there isn't just one way of knowing and everybody's voice is really valuable, it's one way to promote more meaningful cross-sectoral dialogue. And bring in, as you can see here, knowledge from all these different professions. And I don't work in primary care, but I have lots of colleagues that do. And I know, for example, that occupational therapists are becoming vital members of lots of efforts in Canada to really improve primary care. Like, what kinds of conversations are we having? What are the OTs bringing in? And the nurses and the other professionals. So, in terms of shaping policy with moral clarity, and I know this is a health sciences education day, but I think what's really important for us to recognize is that even within an epistemic community whose main objective is to advance better access to care and primary care, there is a lot of policy-related and advocacy-related work that needs to happen. And I recently gave a talk on this topic and said, look, I am not an expert. I recognize it's super uncomfortable for me every time I'm in an environment trying to really understand the policy language. But that doesn't mean that I cannot participate in the discussion. I think what our epistemic community has taught me is that the voice is important, right? Especially when the voice is a voice of dissent, right? Or debate, that everybody has a voice in these communities. Because the policy language, that kind of language which really hopefully moves needles, has to be a language that we start embracing. And my advice is, not once all these graduates have gone into the world and are working. You know, I know we don't have a lot of time in our curricula, but we need to sensitize learners from the very beginning about the forces and the factors that are related to policy and how they really permeate through all the way down to that floor where you're sitting across a patient and a family member. So influencing reforms and advocating upstream, right? So well positioned to push for structural reforms. Epistemic communities can do that. As an epistemic community, we are better positioned to do this kind of work. The power of an epistemic community lies in those differences coming together for the shared commitment to action. And then the learning systems, it's about innovation and systems learning, right? So epistemic communities could also almost be thought of as natural incubators for innovation. How better to innovate than when you come together with these different experts? And then catalysts for change. Epistemic community, the epistemic community literature is very, very long, very, very big, and very, very dense. But one of the things that I really drew from that over the last little while as I read some of this literature is that there is really an opportunity for innovation that comes from these kinds of communities working together, and they become catalysts, slowly, not overnight. The epistemic community, the example I gave you earlier, Dr. Lori Letts, who's sitting right in front of me, is part of this. She knows we've been at it for years and we're moving, I don't even know that we're moving the needle yet, but we are trying to work as an epistemic community. And I'm gonna leave you on this. So I gave you sort of those 4 large areas, but I want you to think about 5 other things that you should consider threading through your epistemic community. The first one is epistemic humility. This is a framework I like to talk about. I won't go into detail. I'm happy to discuss it later in the Q&A or at lunch, but listening, tolerating, reflecting, learning, attempting, and assessing. And I think it's a framework that we can use in our teaching. This is how you begin to try to be more humble about the different ways of knowing, is by listening and then tolerating the discomfort, reflecting on the differences, learning about that, trying something new, and then recalibrating and reassessing how that worked. Everyone has to be involved to some degree on creation, dissemination, and implementation. And what I would urge us to do is to co-create knowledge with communities that are grounded in lived realities and diverse worldviews. Dissemination, folks, is not just about the million publications. Dissemination is about getting that information to the right people in the ways that they can use it. You're not going to get a policymaker, a manager, or a government representative, or an occupational therapist to respond in the same way to the knowledge that you're generating. So that's there's a huge body of work, and lots of people, including myself, that do a lot of work in this, in dissemination. How do we package a message? And implementation should not be left to the implementation scientists. It's everybody's job to be really aware and up to date with the kind of knowledge that we have, and that is it's everyone's role to see how do we move some of this in practice. Leveraging our differences for innovation. This talk that I recently gave, I said, why is there always so much discomfort with difference? I think when it's done with respect and it's done in humility, we should leverage our differences, and we should listen to say, well, I'm thinking this and I'm viewing it like this, and then, Lawrence is thinking about it in this way, or Jeff is thinking about it in this way. That doesn't make us enemies, right? It doesn't make us at odds. So what beauty lies in those differences, and how can we leverage them? Ongoing spaces for dialogue, and I'm not just saying, from 12 to 1, only when there's sandwiches and pizzas. I am suggesting that we deliberately make time for authentic conversations to deal with the different components of the community that I showed you earlier. Advocacy needs to happen for systems to change. We need to do advocacy. My advice is we get the advocacy experts on board and they become part of our epistemic community. And I'm finishing with collaboration, and I'll tell you why I finished with collaboration. It's because it's an overused word, okay? And I hope this is not unpopular on a day like today. But collaboration, the reason why I said true and I underlined it and bolded it is that I think we need to spend a lot more time figuring out what that really means. How do we collaborate more than just because we sat in a meeting for an hour and discuss? True collaboration is going to mean embracing all those different components of the community if we really want to affect change. So that's enough about me. I don't know how long that took, but I feel like let's keep going. Okay, so that's enough about me. It's a whirlwind in epistemic communities. So I now have a few questions for our panel. So now I think we need to move to the chairs. I moved my computer. But these are my questions. So let me read them while our panel sits. So in working together for personal and community-centered care, are we truly prepared to define and clearly express what qualifies as evidence? Embracing research alongside lived experience, clinical wisdom, and cultural knowledge. As an epistemic community, how can we take a more proactive approach to shaping policy discussions surrounding well-being, access to care, participation, health equity, leveraging significant moments in society, and there are many. How can we better support the future generation of healthcare professionals, right? To also embrace this and cultivate critical reflective practices and adapt to the knowledge and the skills. And lastly, what commitments will we make both individually and collectively to exemplify the true values of an epistemic community? And I'm so sorry if these are huge, and I hope we don't run out of time. Now I feel okay. Okay. So now I'm going to turn this off. Oh no, I don't need to turn this off. Okay. All right. So shall we begin with, everybody still see me? Okay. So shall we begin with question one? I need my computer so I can see the question. Sorry. Yes, I will, and I'm going to bring it here so make sure I can see it. So in working together for person and community-centered care, are we prepared to redefine and express what qualifies as evidence? And embrace research, yes, but alongside lived experience, clinical wisdom, and cultural knowledge. So shall we begin with Cathy? You're okay with that? Yeah, okay. I'm just going to sit here so I can read it. Go ahead, Cathy.
Thanks. Thank you so much. My name is Cathy Risdon. I'm a proud McMaster graduate of the class of '92 medical program and have practiced a career of family medicine in Hamilton in various ways now. I'm honored to serve as the chair of our department. And have been involved in interprofessional education initiatives through that time, so I'm just so thrilled to be speaking into this conversation, which has evolved and become so rich. So thank you for framing the remarks. If you are posing huge questions, I'm going to start by moving us to my experience of sort of day-to-day work in trying to, I think, grapple with corners of epistemic community. And that's with the observation that the people who have the practice-based knowledge, who are at the front lines, have never been more dopamine-driven to survive the very next moment and to solve problems that seem imminently attention-grabbing. And the vast horizons of policy change, I think, become challenging. But in that dopamine-driven awareness, I actually think there's an opportunity. And that's to engage in the work of agreeing on the question that will be our guide. And the question has to be bite-sized enough that everyone can see themselves relating to it, but generous enough that everyone's eager to solve it. So I actually think we could do more coming to agreement on the question. because the question is so inherently motivating to bring in the diverse perspectives to move us along and to, again, get the dopamine rewards of seeing progress. So I'll be curious to hear from people what, and maybe as well, Alika, how do we start framing those juicy questions that keep the momentum going and excite the drive that brought everyone to a healthcare profession without feeling overwhelmed by the magnitude of the problem writ large. So I'm gonna stop there and hand it to my partner here.
So my name is Karim Vellani. I'm a family physician, but also serve as the Chief Medical Officer for Shoppers Drug Mart Loblaws. I've been there now for the last 3 years. We are the largest healthcare delivery organization in the country, and right now there's a rapidly evolving scope expansion for our pharmacists. So we're in the midst of trying to figure out how to actually work with our pharmacists to integrate into the existing primary care infrastructure. In terms of what I guess constitutes or what qualifies as evidence, it's a really interesting question. And I think just contrasting my experience in the public system, so I worked in academia for about 10 years, and I've been in the private industry for about 3 years. We obsess in private industry around what constitutes evidence, but also to your point, like what is the shared value, and what is the question we actually want to answer here? We spent days, weeks, trying to figure out strategy before we actually go out and execute, because as Aliki referred to, when we're thinking about epistemic communities, shared values is one of the first steps, and unless you actually get that right, anything that comes after that is just probably not going to work. And I think we see that time and time again in healthcare. I think Andre Picard, and I'm paraphrasing here, once said that like Ontario is the land of 1,000 failed pilots. We're good at creating pilots, but we never actually do well in terms of executing and scaling up. And then also the other thing I would say is we should challenge a lot of assumptions we've had historically in the healthcare system too. Although a lot of it is well-intended and we use evidence or published articles that help guide us, there's a lot of lived experience we can actually start to incorporate into how we actually design systems. And there's a wealth of knowledge from industry and corporation as well that we can offer too. I think there's a bit of a hidden agenda sometimes in academia. I was there that, corporatization is a bad thing. But I think when we start to dig down and actually have discussions about shared values, I think there's actually alignment there in terms of what we want to achieve together. So I would say in terms of what constitutes evidence, we should start to challenge and ask questions around what is the evidence that we've been formally building off of, and what can we do a little bit different going forward.
So sorry, so you think we are prepared to redefine?
I think we have to.
Or we have been, or you think?
We've been trying.
We've been trying.
We've been trying to, and in a very, I guess, political and sophisticated way. But I think it's conversations like this where we can actually have open dialogue and really challenge a lot of what our assumptions have been and what the status quo has been. Because I don't think we can just keep repeating the same thing over and over again. And I think historically that's what we've kind of done. I think we're at the precipice of real meaningful change, and to what you said earlier, it's going to take a long time. It's not going to be overnight, and I think there needs to be patience exercise in all aspects of our healthcare system to wait for that change to evolve. Sometimes we're quick to evaluate and shut down our pilots, but I think if we are going to move forward and actually evolve our primary care system, we have to be prepared for the long haul. And I think it's going to take a lot of discipline, a lot of patience, and a lot of investment from every party involved.
Hi, my name is Ruth. Ruth Hannon. I'm from the School of Nursing. I practice as an NP as well. And when I look at the evidence-based practice, I find it interesting that the novice practitioners really rely on that scientific base. And as you move in the trajectory and you get further away from school, you start to integrate that acquired knowledge. And that has real value in terms of individual patients. I think the patients are driving the expectations that we start to listen to them, and how we morph that into education, because you can't give the lived experiences without the background of the evidence-based, but there's a trajectory in there, and having room for both of those to grow, I think is an interesting point. I think we're being challenged by patients to figure this out faster. and they're going to drive if we can't do it as healthcare professionals.
Yeah.
I'm finding that other systems, corporations, other places will do it for them, for us. And so sometimes it's get on board and we jump in after the fact.
No, I appreciate that, and we've had lots of discussions in our circles about the patients or the end users, or whichever expression. I know some expressions rub some of us the wrong way, but to the extent to which they're driving the momentum, and I really, really like what you said. It really resonated with me. You know, if you find, most of us have been, I think, users of a service, a medical service, and you know, when we say we want answers, I'm going to tell you my lived experience of this condition. What you're telling me is not going to work, right? And so maybe there's more of a push. Maybe some of it needs to come from the bottom. I'm not a physician, but thinking of meeting, I've had moments where I've been with mine, for example. Yeah.
I would just add on that, like,
Yeah.
the system we've built around that interaction makes it really hard sometimes to actually, like, go beyond just the evidence. Whether it's regulation, whether it is, you know, you're held to a certain standard, sometimes to actually deviate from what, let's say, an RCT or guideline says, I think there's a bit of risk averseness there. And then I think earlier to your point, Aliki, the silo discussion, when we start to build in silos, it's really hard to change. There's a real resistance to change as well. I'm guilty of that too. As a family doctor, I become resistant to certain types of interactions or certain types of workflows. But I think we have to start to challenge everything that we've historically done if we're actually going to rebuild this primary care system.
But I think, you know, just the moment you say I'm guilty of that, you're already on that framework I proposed, right? You're suggesting I'm not perfect, I have a lot, you know, and we've said it, OTs have said it, nurses have said it, I'm not saying this is just physicians, but already you're recognizing the humility that it takes to say, okay, I probably could do a little bit differently. So thank you for that. Okay, shall we go to question? Did you want to add something, Cathy?
Just to add another observation about redefining evidence and the aggregation of powerful evidence rested in the human experience of our care systems. And so it feels like there's another asymmetry right now about the kind of evidence family physicians or physicians can amass through our advocacy and groups and so on, and it's a very powerful voice that crowds out other forms of evidence that are so important. And I often imagine the distribution of misery in our population for every individual who sort of suffered from a fragmented system. And all of you know stories in your families of sort of failed moments of receiving care or of getting what you need or of not being able to access critical rehabilitation services. But those stories are distributed into the ether, and they're told at family dinners, but there's no way to collect them. And if we had a switch that could collect the misery that's distributed in our communities that people are experiencing and bring that to policymakers, it would crowd out what the OMA is saying. So I don't know what, I'm often wondering how to work with the advocacy groups to collect that evidence in more force.
So I love that you brought that up. So in our epistemic community, we are working with the PAN, the Patient Advisory Network in Canada, and they've become not just our biggest friends and allies, but they're the kind of people that are going to say you're dreaming in Technicolor, but they're also going to tell you we will go knock on doors. There's a lot of power in patient advocacy groups like those. You know, different conditions who've really been struggling, and they're bringing, I wonder if that's not one way. So maybe in all of our epistemic communities, and this one in particular, we need to have the patient group there. I don't know what you think as physicians, but that's what we're trying to do with ours. Yeah. Okay, so number 2, as an epistemic community, how can we take a more proactive approach to shaping policy discussions surrounding well-being? And I think selfishly, the reason why I'm asking you this question is because I know that we work hard in concrete outcomes. We want to reduce blood pressure. We want better screening for breast cancer. We want this, or we do concrete things, right? We want to make sure a child walks by X age, right? But how do we embed more than just those things, right? How do we use an epistemic community to advocate with policymakers on issues of well-being? participation, let's use, WHO, ICF language, right? It's more than just, I got my blood test and I need pills for my high blood pressure, but at a broader level, which is what our society, I think, is aching for. What do you think?
That's a good point. I think, unfortunately, there aren't the right types of incentives in the system right now for patients, like to actually drive meaningful change. I mean, we're all in a room here talking about how to reframe or how to shape primary care. You don't see patients, outside rioting. You don't see people saying we need to make this change. I think patients at this point have almost kind of given up to some degree in terms of how they're going to engage with the healthcare system. I think it's beholden to us as system leaders to actually drive that conversation, to be proactive, to work with governments, to work with institutions, to work with grassroots clinicians and patients to actually figure it out. It is reassuring to see that we have a primary care physician now at the helm, at the primary care action table, which I think is not just an important symbol, but also, given her expertise, Dr. Jane Philpott, I think we can start to see kind of light at the end of the tunnel here. I think we're starting to see shaping of the healthcare system a little bit. We're starting to see the right system stakeholders come to the table, but I think we need to really push the envelope here. If we start to take our foot off the pedal, we're just going to revert back to old ways.
Yeah, Jane has been such an amazing champion. I had the privilege of meeting her on Zoom for this episode of Community, and I remember her saying, I wish there was an occupational therapist in my environment or in my, in my geographical area, the way there's schools in every district, and it was much, the discussion was much more complex. But somebody like her is such a champion. So yeah. So go ahead. Yeah.
I think defining well-being,
Yeah.
that's a huge thing. What do patients want? Do they want unfettered access 24/7? It's not, we can't do it. We have expectations for an infinite system, but we work in a finite world. So while they want a lot of different things, some more than others, the equity, I don't know how you do that. There's only, if a family doc has, 1,800 patients, they're not seeing all of them this week, no matter what you do, and no matter how you carve up that day. And not everybody needs to see them that week. People are heavy users with light users. I don't know how you always get to that full well-being, because I think expectation drives that. And different areas of the population. I mean, I work in the Burlington area, and I do find that they have access to information, they have access to health benefits, they want to use all those health benefits, they would see it as a waste not to use them. So just to what their expectations are, I find are higher than maybe some other areas of the community. And that shapes how we practice too. We enable some of that behavior. We try and keep them happy, which we can't. So how do you define well-being? Because I think it's different from a practitioner versus a patient.
It feels like there's another strategy that we're trying to explore with some primary care approaches in Hamilton, and I think of it as redimensionalizing people into a place. So I think there's something geographical about well-being, and there's something about where you live and work and the identity that is formed by your physical geography, and the networks that may or may not be available based on you being in a place. I think the move to virtual care and the Uberization of all healthcare has so emphasized the transactionality. We've lost some locationality, and I think could be a key to well-being. So partnering with social prescribing, who have I think are reestablishing location as a way of understanding health. And then the assets outside of healthcare that might be in a place, I think is important. So we've worked with public health to make an atlas of primary care in Hamilton. And when we have a discussion about solving a problem, we're actually looking at the neighborhood. And it changes it changes the abstraction nature of some of the problems we try to solve. So maybe there's another dimensionality we can be thinking of for well-being.
Okay. Great, and we have, so can I just have again a show of hands, the students? Students? Wonderful, majority, great. Yes, Jeff, you are an eternal student, we all are. How can we, so this is my favorite question, because I think that if we're going to be on to something huge. So how can we better support the future generation of healthcare professionals, right? The people that are in our classrooms now and in our graduate programs in cultivating critical, reflective, and adaptive knowledge.
Again, infinite expectations in a finite world. I mean, nobody wants to add more years to how many years it takes you to get the degree. If anything, we're trying to morph more in. Put this in, put this in. Oh, we didn't talk about this, put this in. And I don't ever hear a conversation about, well, if we put all this in, what do we take out? So there are super high expectations about everything possible that somebody needs to know. And then you get back to your silos. What does your profession demand that you have? And then in the background, whether we want to think it or not, you've got the litigiousness. How do I keep myself safe?
Yeah.
And we're trying to, I don't know. I mean, that's, again, a super big question. Lots of exposure to patients. I think certainly in nursing, there's discussion about, can we do some of this virtually with mannequins, things like that. But you gotta have real life experience and conversations to build up that life information.
So just, if I may just respond to that, and I want to hear the panel as well, is my challenge though is this about adding content? Is this, are we doing standalone courses on what I named cultivating critical, reflective, and adaptive knowledge systems? Is that about teaching content and modules, or is it an opportunity to do other things that are creative, right?
I agree. It's part of the identity with the profession, helping them teach that information, but we get into the what are the expectations for that licensing exam.
Right.
So yes, I absolutely want to teach that. I think it comes in different ways, but we're still bound by, we need these people to pass. We need them out there. So it's hard, yeah.
This might be a little bit drastic, but I think there needs to be a bit of reshaping in terms of how we educate future generations of healthcare professionals. We did a good job training, and I'll talk about young doctors, training young doctors in highly resourced, highly funded, team-based environments. But when they go out into the workplace and they're not able to get a job in one of those environments, they're probably working more in a solo clinic, maybe a small group of clinicians, and they have challenges adapting to those types of practices. And as a result, they take on different types of challenges in the workplace. They have disruption of work-life balance, working from home with them. Not to say that it doesn't happen for team-based care in high-resource settings, but I'm not sure we're actually setting up our future generations of trainees for success if they have to go out into the community in low-resource environments. Furthermore, as someone who works very closely with pharmacists and other types of healthcare professionals, I think we need to do a better job of actually stepping into the shoes of other types of healthcare professionals. So when I joined Shoppers Drug Mart, I actually worked as a pharmacy assistant for a couple of weeks just to actually understand how do they actually operate? What is their true scope? What can they actually do? And that helped me actually better appreciate how I could actually use a pharmacy, whether they're co-located or distributed in a manner that actually helps serve me and my patients. And I would say if you're not getting the experience right now as a clinician in your with other types of healthcare professionals, challenge your supervisors and ask, I want to go work a day or a couple of weeks with another type of profession. If we're going to build, team-based care environments, we really need to experience what other professions are actually encountering with their patients and in their profession. So I would challenge anyone who's in charge of education policy to actually think about how are we actually going to ensure that our clinicians are actually getting the right types of experiences to actually facilitate meaningful change when it comes to team-based care.
Noted, I love it. I totally agree with that. I'm also thinking there's an opportunity in the pre-professional program space. And I love the phrase structural competence, structural literacy, because it feels like once you're in a health professional program, you're being taught the exact nature and texture of the hammer that is associated with your job, and so everything you see becomes the nail. And I think there's almost there's a blindness to the structural competence needed to enter the communities of humility, because you don't even know how to claim what you are, you just know how to do what you've been taught. So I think if you get a chance to talk to Lawrence today about admission policies into medical school and how that eliminates a lot of opportunity for any epistemic humility ever, I think it's a good conversation to have, and maybe we need to rethink the kinds of competencies we want to invite into a health profession training programs, and really value some of the interprofessional chances for learning before professional training to bring a critical eye and an eye of humility and the chops to challenge the assumptions baked into professional training programs. I think maybe we could go upstream a bit too.
The chops to challenge the assumptions. I like that. That was one of my slides too. It said, let's challenge the assumptions that are there. Oh, that's great. Where's Lawrence? Oh, Lawrence, how are we doing with time? How long do we have?
We got 20 minutes. Do you want to do question 4 and then we'll go Q&A?
Yeah, so what we'll do, that's what I thought, great minds. Okay, so we'll do our last question and then we'll open it up for hopefully some discussion from the audience. Okay, so folks, what commitments are we ready to make, both individually and collectively, to exemplify the values of an epistemic community? Are we ready to commit? Right.
I think it's easy to say yes.
No, it wasn't yes or no, it's
But-
what commitments?
I think the commitment right now is we need to push the dialogue, not just have
Push
it.
the dialogue.
I think right now we're at a point where people are still shaping policy, that there's an ability for us to actually inform them in terms of what meaningful policy looks like and implement change. As I said before, we just can't rinse and repeat, and I think we really have to have dialogue with different types of sectors, whether it's private industry, academia, public policy. I think really we need to bunker down and really push the needle forward, or else we're just going to revert back to old ways. And I think not just having the discussion, we have to think about all the different enablers too. Often when we don't consider what the blockers and barriers are for evolution, things inevitably fail. So we can do a great job as important building, let's say a pilot at 1, 2, 3 different locations. But how do we problem solve for the different types of phenotypes of patients within our community? We do well maybe solving for 80% of our patients, but what about the other 20%? How do we actually problem solve for them? I think it's going to be beholden to all of you, future generations as well. Share your voices. We want to build a system that actually works for you. Our time is pretty much up, to be honest. So let us know, what type of environment do you want to work in? How are you going to be able to work and sustain your livelihood when it comes to primary care?
Yeah.
I mean, yes, the commitment, I think, is there. I think primary health care never before has been on the premises of being destroyed, right? It's not doing well, tons of stories of people not getting the care that they need, the horrendous wait lists, the referral components, all that, there's lots of mess out there. So we've got a unique environment. I think our culture is ready to blow it up a little bit and reshape it. Are our politicians on board? And until the money flows, I think that's going to be a huge stumbling block. But I think we're getting ready to really reshape some of this, how healthcare is delivered at a primary care level.
And do you think it's because we've reached the breaking point?
I think it's in such disarray that it, on certain levels, I'm not sure it can do anything but get better.
You know, just a quick anecdote, if I may, with Jane. So again, I'm in a Zoom call with Jane, and I'm bracing myself because I really want to say something, and respectfully to the ex-minister of health, right? And she's a Queens now, right? And so I'm thinking, how am I going to tell her what I really want to say is, you know, I believe that we've reached a point where we are harming citizens. I said, okay, Aliki, take a deep breath, say it nicely, make it sound like you're not, you know, attacking Jane. And she just said to me, I couldn't have said it better. You're absolutely right. We haven't reached, we are harming people, the system. And so, again, you know, I wonder if the revolution needs to really come from the patients. There's harm, sure. Thank you. Cathy, what do you think?
Yes, ready to make the commitment. It feels like I need to talk less to the people I've talked to for the last 40 years and more to people I've never talked to before. And that feels like so, you know, some quick examples. Our School of Global Health is looking at social medicine. And I'll just confess that I hear that phrase and I think, oh, that's what family medicine's been doing all the time. Why haven't they talked to me? And I'm like, okay, my head is shake. It's my job to understand the world they're coming from. It's new and emerging, and it'll be me that reaches out for that relationship. Why would I expect them to come to me? And I think there's habits of interaction that preserve the status quo that we have to challenge ourselves to break. So I'm going to commit to talk to people I haven't normally talked to. I think that's important. It feels like the academy we could talk to each other within the academy. But you know what? I've met with my colleagues in nursing and rehab where we feel very motivated for something new to happen. We actually don't know how to make that happen. So what are the enabling containers, and maybe the epistemic community can help us name some of the enabling next steps that, as a school who really cares about health, we could use a bit of guidance to have the conversations that could transform how we're doing our business. So I think there's a next stepness in moving from the research to the actual. If we sat around the table for a day, how would we talk to advance this? We're still a bit locked in our habits. So how can you help us as an academy and private partners sit and have a meaningful conversation in Hamilton to advance this thinking? Because I think the hunger's there.
I love that, speaking to others outside. And again, I know, Laura, this will resonate with you, but in the moments in our bigger epistemic community where I wanted to say something, and there's social scientists or political science people or managers in the group, and I'm thinking, yeah, well, we have all this evidence about effectiveness of rehab. Push it into practice, you know? Not quite like that. But I've spent my career studying this knowledge translation process. And it wasn't until I said, I have to talk to the people who say to me, that's not how it happens, Aliki. Evidence doesn't always drive decision making, but it's so uncomfortable. It's what you just said, and what I said in the talk, right? I'm so much more comfortable when I'm with myself, with my silo of implementation science people, right? And when you expand that, it's super uncomfortable. But maybe the epistemic community will allow us to have that space to do it. All right.
Let's just take a moment and round of applause for. We have a good portion of time to open up the questioning to you all. Raising hands is the way to go, and we'll start with you in a second. You've all decided to sit at the back. I'm not going to run the microphone around, so please be as loud as you can. If you have a comment, I'll come up and I'll try to translate down as needed, okay? And the question can be for Dr. Thomas or any of our panelists to look at, so please.
Excuse me, theater voice, can you hear me? Okay. So I have a question specifically related to maybe power and equity and access within these networks. And I'm thinking specifically about, this is my first day here, I'm not going to make any friends, specifically about research that's coming out of this institution under the guise of evidence-based whatever, that is in direct conflict with sort of trans health experts with trans health networks in this province, in other provinces, the WPATH standards, all of those things that are now being sort of used in legal battles that are happening across Canada. And so how in these networks do you ensure that the people who are the most affected by the decisions that are going to be made are actually a part of these networks and are being, I guess, like you talk a little bit about the different kinds of knowledge and how they need to be, like, but what is the process that makes that equalization happen, where we're not maybe prioritizing certain kinds of knowledge over other kinds of knowledge just because of access to power?
Guys, was it for me?
For anybody.
Oh, well, I could just tell you what's happened with our academic community, but also what's happened in my own research over the last 20 years. The first and most important thing is that it takes a lot of time to build trust. To build trust with communities that are underrepresented, whether that's Indigenous communities that are part of our group, whether it's, groups with disabilities, whether it's, LGBTQ groups. There's a lot of different groups. In this big project we're writing together, we list them and we explain in which way they've been marginalized. We talk about epistemic injustice. We give examples about the ways in which their voices have been silenced. So there's no silver bullet. It takes a lot of humility. It takes a lot of time to garner their trust, because what you really want is you want them on board. No, none of this community will work. Ours will not work, because it's not people like me that don't have access to rehab, right? I'm the highly educated white woman with a good salary, you know what I mean? These are not the people whose voices need to be represented. So we've had to, in French they say mettre de l'eau dans son vin, so put water in your wine, or whatever that expression is, right? We've had to be super humble. We've had to recognize that authentically, because they push back. When you go to a meeting with any of these groups, you've named so many, there are many more, and you attempt at showing the humility, they will so make it clear to you that you've taken it out of a textbook or on the internet, right? They will really challenge you to demonstrate the ways in which their voices will be represented. And there's some best practices, there's some literature on how to do that, but I think that relationship building is what takes the most time. But they have to be part of those communities. And I could let my colleagues speak about this one if we put it forward. The patient voice will have to be there, and not just one kind of patient. How, even within the patient groups or the user groups, who gets to decide which voice needs to be represented, right? I don't know if you guys want to add anything. Does that help?
It does, yeah. I sort of, yeah. Yes.
Yeah, just one more thing I would add to that is we also have to recognize that data isn't always all that informative in scenarios too. And I think when we're creating sweeping policy changes, we use data to inform us. We have to recognize that there needs to be probably a bit of a drill down in terms of where there's an absence or lack of data when it comes to the specific patient populations, and really rely on the patient voice or frontline providers to actually inform us of what's happening on the ground. It's very easy to get lost in a room with just an Excel table or a data set and make a policy decision. So.
And I'm not sure if there's one part of your question that I did answer. Yes, we are in the home of evidence-based medicine, but if everything that we've been doing in the last hour actually really matters, is to say, what are the blind spots of evidence-based medicine? And when we are sitting in a group as large as the one I showed in our community, what evidence matters? And when I talked about the third construct, or the third set of values, is about what do we believe to be legitimate knowledge. And there will be times where the community says we need evidence of effectiveness because we need to show this number of individuals will do better after they've had 6 weeks of rehab, right? But that there's other study designs, there are other ways of knowing, and all of that needs to be aggregated into what the community is trying to achieve. And so there will be some people who will have to advocate for methods and evidence that don't only come from randomized clinical trials. The patient voices, the community, the nuance, right? Those kinds of things. He has a question.
I can feel the question.
Yeah. From the get-go, I was puzzled by the term epistemic community. Fortunately, my son has a master's in psychology, so at some point I was the epistemic is like epistemology, it's a kind of knowledge. And I think the kind of knowledge I think is what knowledge and disciplinary knowledge, not profession. I think if we go back to 1992, I suspect that guy was talking about disciplines like psychology, biology, and anatomy, not professions like medicine. And I think that's an important distinction to be made, because essentially what you've created is a yin and yang, where the yin is my boy Dave, and primacy is around my controlled trial, and at one point, around the CD and me long enough to remember when Dave stood in front of him and said, "We will say, gentlemen," and we were gentlemen. But the only form of true scientific knowledge is a randomized controlled trial. In the background of nuclear physics, I just say to myself, I don't recall doing any randomized controlled trials on newcomers. So that is a very narrow view, but the alternative is there's a totally level playing field. Is also, I think, problematic. We haven't really taken on this question of how do we prioritize performance. They're not all equal. I'm looking at this instructor because most things in medicine can be always, well, maybe, the classic last line of every systematic review I've ever read is, A, the research sucks, B, we need more research. So it's easy to leave room for other kinds of knowledge. But at least there's one where it's an interesting counterexample. Shopper drug mart, I've taken on individual managers of shopper drug mart because there's a considerable amount of shelf space devoted to homeopathic remedies. Now, King Charles III notwithstanding, there are a few areas of medicine where it's well defined that homeopathic remedies cannot possibly work except in placebo effect. You have to be blunt, I would say that Shoppers Drug Mart and other pharmacies are unethical in marketing. Somebody should say, no, that's one where you know the answer. What I'm suggesting is that by blurring practical communities with research disciplines, that you might really be muddying the waters and making your task much more difficult in terms of moving forward. Because all knowledge is not equal.
No.
For some questions, some kinds of knowledge are important.
Yes.
For other kinds of questions, you need different kinds of evidence. And that actually might make life simple, because if you can prioritize around the nature of the questions, that's a lot easier than trying to get everybody to agree on everything.
So I'm really glad that you mentioned this, Jeff, and I had 30 minutes, but in a recent talk where I had an hour, I went into epistemic relativism. So I really do want to nudge to what Jeff just said is really vital. It's not, our epistemic identities and epistemic pluralism doesn't necessarily mean all knowledge is equally valid at all times. I am sure that when you are walking into an appointment with someone who has your life in their hands and you have to do some sort of, life-altering intervention, it's not just about embracing everything I just said, everything just goes, right? And so not all knowledge is equal always for the similar things. What we're trying to say, and to see whether this concept applies for our teams, is to say, are there moments and spaces where these different ways of knowing can come together at different points of time in the process for the greater good that is access to primary care. And so there will be things that Cathy will bring in, right? And we'll speak as physicians to the group and say, this is the data that we have. And the patient voices will come up and say, we need to alert you to this. And then the implementation science people will come in, and the community organizations will come in. So that's really about the concept more broadly of the epistemic community, but doesn't mean any knowledge goes at any time without scrutiny. I can get into that. But thank you for bringing it up.
And maybe I'll just add, the harms we are causing humans right now is because our system can't deliver on a lot of the evidence that science has taught us.
Exactly.
So this is why we need.
Exactly. There's a question there?
Is there one? Yes, please, Tasha.
So it was mentioned earlier that geographical location is a large contributing factor to barriers in healthcare and receiving healthcare. So I was just wondering, for issues that are more systematic in nature like that, where it's like built into society that these people, because they're in poorer places, because that's where there's like society wants them to be, like what is a good strategy for starting to combat something that is so embedded in our culture and society?
I can just speak to you about the experiences I've had working with Indigenous communities in Manitoba, and I'm not an expert, so I do say that with humility and a capital H, our experience, but there are also other kinds of communities just in Quebec where we can't access, right? That by the time something is happening, there's symptoms, somebody thinks they're having a stroke, by the time they get to a hospital, et cetera, et cetera. What we've seen with both sets of communities is that there's a lot of different things that they're telling us would work for them. Going into those communities for a long period of time and educating the communities about what are the first signs of a stroke. First of all, never mind prevention, to eat better, et cetera, et cetera. Again, recognizing that that's a whole other systemic issue. There's the education. It's hearing them what they need most. I need to know that I can call my doctor. My child is not sitting and they're 14 months old. How do I get access to an occupational therapist or a physical therapist? So we're listening to what the needs are of the communities, and then we're trying different things like education, like virtual. Like virtual is becoming really, really big. We're testing things out like, if that parent shows us their child not sitting and we're looking at their tone and it's an occupational therapist in a different city, can that be a method to screen for what's happening? Recognizing, again, that technology is costly. So how do we embed things and then sustain their use? So there's a lot of different things that we're trying with yet no silver bullets because they work for very little time, but it's the sustainability that's difficult. We've ended all these projects with Indigenous communities in northern Manitoba, and now we're hearing, where are you going to be next year? So from the get-go, they told us years ago, if you come in and work with us and help us, you better make sure that once you leave, all of this is staying there. Another thing we're doing, I don't know about what MAC does, is we are trying to put in educational systems to educate and train more OTs, more PTs, more physicians that go back to those communities, etc. There's many.
So like educating communities and like foster communities.
It's been taught for us. It's educating communities. It's very difficult to go into a group, into an Indigenous community and say, well, you need to eat better. And then just the environments are not built for that because of the systemic oppression and just what's going on in those communities. So it's working with, what food do you have access to? Is there a possibility to grow your own food? It takes years, months and months and years to understand their reality so that we could co-construct solutions with them. They tell us what's going to work for them, not the other way around.
Okay, we're getting to time. The conversation isn't necessarily over. The members of our panel will be around today. I'm not sure if all of them. Dr. Thomas certainly will be, and available to chat. Towards the end of the day, we're really honored to be able to welcome Dr. Marco Zaganini, who's a respiratory therapist and a health science education alumnus, and Aliki's PhD graduate student, who's going to continue this idea of epistemic community and scholarship as a wrap-up for our day. So as we're having these conversations, we're going to hear a little bit of a cap on those ideas later. So there's more chance for that along the day. And the folks that are here for the HSED Residency Week, both Marco and Aliki will be joining our curriculum for tomorrow's events also. More chance to talk about them. You can find all of the information about the schedule at normanresearchday.ca. Samantha, Sanana, Courtney, and the whole team are out there to help you. And we have a short break now, and then our concurrent sessions are going to run. There's posters at lunch. And just before we go, can we